Hello, everyone. My name is Sheena Siddiqui. Welcome to our presentation on severe risk in young women taking oral contraceptives. I, along with Anne Barade and Jennifer McCoy, are going to present on a research proposal on this topic. Background. Cerebrovascular accident is characterized by the onset of neurological deficit, depending upon the area and the offending cerebral circulation affected. It can be classified as ischemic or hemorrhagic. Most strokes are ischemic due to reduced blood supply resulting from arterial occlusion, and in rare cases due to venous occlusion of the sinuses. In 10 to 40% of cases, it can be hemorrhagic due to rupture of cerebral arteries, which can present as intracerebral or subarachnoid hemorrhage, later being because of rupture of aneurysm. The key clinical feature of stroke is the sudden onset of focal neurological deficit without headache, confusion, seizures, incontinence, vertigo, numbness, visual changes, and memory impairment. The most common risk factor for stroke include diabetes, hypertension, smoking, increased cholesterol, previous history of stroke, atrial fibrillation, and illicit drug use. In women, the incidence of stroke is highly associated with hypercoagulable states like pregnancy and exposure to exogenous sex hormones in oral contraceptives. There are several causes of stroke in young adults, including arterial, venous, and cardiac causes. Extracranial arterial dissection accounts for 10 to 25% of stroke in younger population. Prompt diagnosis is needed to start early treatment and management in stroke patients to decrease the risk of morbidity and mortality. CT scan head is done to diagnose stroke in patients, and treatment is with antiplatelet or antithrombotic, depending upon the type of stroke and time since the onset of symptoms. Blood pressure management is of great importance in stroke patients. Intensive blood pressure control, lifestyle modification, smoking cessation, dietary changes, better glycemic control, discouraging drug use are the most important preventative measures. Moving on to the findings of literature review. Stroke is the second most common leading cause of death worldwide and is known to be the most common etiology for physical and cognitive disability. It accounts for the fifth most common cause of death in the United States, with increasing economic burden of treatment and post-stroke care. Stroke has always been perceived as a disease of old age, but its incidence is increasing substantially in younger population that is less than 50 years, accounting for 10% of stroke cases. The incidence of stroke in the United States is increasing with approximately 17 per 100,000 cases in 1993 to 28 per 100,000 cases in 2015 among young population between the ages of 20 to 44. Another study conducted in India from 2003 to 2005 conducted that the risk of stroke was 4 per 100,000 in individuals less than 40 years, but it increased drastically to 41 per 100,000 for individuals between the ages of 41 to 44. Young women are more at risk of stroke as compared to men of same age group. A meta-analysis of 19 studies also observed that 44% of women less than the age of 35 are more susceptible to stroke than men. In the United States, OCP is the most common method of birth control, with over 10 million women relying on it, with 78.5 million women are prescribed OCPs worldwide. Since the introduction of oral contraceptives, they have been associated with several adverse health outcomes, including stroke, MI, and pulmonary embolism. Currently, oral contraceptives are associated with 2.47-fold increased risk of ischemic stroke, with a relatively low risk in normotensive young women who are non-smokers. It has been reported that those women who use oral contraceptives with ethinyl estradiol at a dose of 30 to 40 are at risk of developing arterial thrombosis, which is 1.3 to 2.3 times higher than non-users. Women who use pills with ethinyl estradiol at a dose of 20 are at 0.9 to 1.7 times more at risk. There has been an observed small risk of stroke with different types of progesterone contraceptives. Purpose of the study. It is currently recommended that any women, the purpose of the study are, we like to answer these two questions. Will the increased availability of pharmacy access for oral contraceptives have an increased incidence in stroke in this population? Is the risk for CVA in women aged 20 to 45 who are taking oral contraceptive prescribed by a PCP, or is the same as women in the same age group taking oral contraceptives provided by written and dispensed by a pharmacist? Aim of the study. In the summer 2023, the FDA approved the first over-the-counter oral contraceptives, OPEL, to improve the practical access to family planning. Currently, 29 states have pharmacy access laws that allow pharmacists to prescribe and dispense hormonal birth control methods. Indiana, in Indiana, the House bill, which was signed into law on May 1st, 2023, allowed for pharmacists meeting the requirements to prescribe self-administered hormonal contraceptive, both patches and oral contraception, to women after consult and without physician visit. The aim of our study is to explore further relationship of pharmacy access to contraceptives, and if the adverse outcome of CVA is any higher in population receiving contraceptives from prescribed pharmacists versus women who prescribed contraceptives from PCP providers.
So moving on to study population, we decided to focus on women aged 20 to 45 years of age. And the reason that we arrived to this population is because not only are nearly all women going to access contraceptive in their lifetime, but according to the CDC, from 2015 to 2017, 64.9% of women in the age group 15 to 49 in the US were actively using contraceptive, and an estimated of 12.6 of those women in this age group were utilizing oral contraceptives. And this has increased over time. Now, according to the CDC, from the years 2017 to 2019, 14% of women in the US aged 15 to 49 are currently using oral contraceptives. Current research also notes that in terms of incidence of ischemic stroke in young adults, women in the age group of 35 or less are more affected than men in the same age group. So then following up with that, our sampling method. In gathering patients to participate in the study, we'd like to gather from a local retail pharmacies to achieve a large enough sample size to allow generalization and application of the results. The hope is to enroll 3 locations from 3 pharmacies in locations from CVS, Walmart, or Walgreens, so a big retail business in one of the states that allow pharmacy access. And the goal is to enroll 2,000 participants. The reason we arrived at this is because the sample size needs to be relatively large enough to gain data, but not so large that conducting the study is impossible or inappropriate. A challenge that we may have in conducting our study is due to the overall low incidence of our health outcome. The low rate of recurrence may not provide enough meaningful data for the study, or we may have to expand in order to obtain that data. And then furthermore, moving on to exclusion criteria to protect the integrity of the data in the study, we chose to exclude participants with a prior history of CVA, and the reason and rationale for doing this is that, according to the American Stroke Association, approximately 1 in 4 patients with a CVA history will develop another CVA. And then additionally, upon initiating oral contraceptive, we are wanting blood pressure to be measured by the researchers, and participants with a blood pressure greater than 140/90 are going to be excluded because they need further follow-up with their primary care to manage that hypertension. And the rationale for excluding them is that multiple literary studies and reviews have noted and identified that hypertension is one of the single most prevalent risk factors for stroke. We're also going to exclude patients who are already on a contraceptive method, as we are following a prospective cohort design, as we will discuss in the future, and we want to follow that patient and the outcome. So moving on to our study design. As I mentioned, for our study design, we're using a prospective cohort design, with the cohort being women in the age group taking prescribed oral contraceptives through pharmacy access, and the control being women in this age group taking prescribed oral contraceptives from, in the traditional way, from a primary care prescribed or GYN. And the exposure is defined as taking oral contraceptives as written and dispensed by a pharmacist only. Outcome would be CVA. We arrived to this kind of design because we wanted to follow the patient through. We thought that that would provide the strongest data because the patients in the groups do not have the health outcome. And then additionally, it would be difficult to look retrospectively at this data because legislation has been recently changed regarding pharmacy access when it comes to contraceptive. So some of this is relatively new, and that's why we decided to look at this prospectively instead of retrospectively. Additionally, because of the nature of the cohort study, the establishment, as I mentioned, or relationship or lack thereof could strongly be made, again, since the participants at the beginning of the study do not have the outcome. So our study is going to follow voluntary participants who are initiated on oral contraceptive methods, and we chose a 6 months period from January 2025 to May of 2025, and then we're going to follow them for a year and 6 months with a possibility to increase that length of time if funding allows. Um, while most cohort studies are relatively long in nature, the time period we chose is relatively small, and we justified this because current studies are suggesting that the first year or so following the initiation of oral contraceptive is when the individual is at most risk for developing stroke. Additionally, on the side of this, you will see a graphic just kind of going through those stages that we're talking about with participant selection and then arriving at data. Um, Moving on to instruments and variables that we want to kind of hone in and look at. So variables that we'll be gathering from participants are age, race, um, location, their smoking history, BMI, if they have any history of migraine, if they do have a primary care, their date of last wellness visit, medication list, history of AFib or any bleeding disorder, if they're active with a GYN and their last visit, as well as the type of oral contraceptive being used and the doses of estrogen in that oral contraceptive, if any. And then moving on to equipment and personnel needed for the study. So we will require cooperation from pharmacy personnel to conduct this. And then we will need at least 3 to 4 researchers per pharmacy to handle participant introduction, enrollment, and then assignment into groups, whether they're obtaining the prescription from their primary care or GYN or accessing this through the pharmacy and consulting with the pharmacist only. Additionally, because we're requiring that blood pressure be monitored upon initiation, we will need blood pressure cuffs as well as staff that are capable of obtaining blood pressure. After the voluntary participant completes the intake assessment with the nurse or researcher, the patient will be followed up monthly via phone to ensure compliance with their group and medication. We're also going to verify that the dosage remains the same and nothing has changed. And then also see if there is any reported incidence of stroke. If an incidence of stroke is reported, attempts will be made by the researcher to obtain medical records and really verify that diagnosis. And these monthly phone calls can be conducted by an unlicensed personnel. And each participant will need an emergency contact upon initiation and enrollment so that uh, in the case that they are unavailable, we can continue that follow-up. And then factors of possible association with CVA that we need to take into consideration. So one factor in association with our health outcome is the type of oral contraceptive utilized by the participant. Currently, it's reported that a quarter of women aged 15 to 44 utilize oral contraceptives as their choice of birth control. And the two types presently are combined estrogen progesterone pills, which are the most prescribed form, and then progesterone only pills. So current research indicates that the risk of stroke in women using a combined oral contraceptive is 1.6 times greater than those women not taking an oral contraceptive. And then additionally, smoking is a strong behavioral factor that has been well documented to have an effect on CVA incidence. One study cited that smokers have a total increased risk of 1.6 greater odds to experience a stroke than non-smokers. Other factors possible in association include history of migraine, uncontrolled hypertension, and active infections.
We will also be doing, like we said earlier, the primary outcome for this cohort study is the occurrence of the cardiovascular accident, specifically ischemic strokes confirmed through medical records or neurologist evaluations. The oral contraceptives alone, in the absence of smoking, hypertension, or migraine, significantly increases the risk of stroke. Regardless of the use of non-use or use of the agents, hypertension is a risk factor for development of either thrombotic or hemorrhagic stroke. Regular cigarette smoking and history of symptom is indicative of migraines also increase the likelihood of one or the other types of stroke available. In this cohort study of ours, we have many different safeguards that we are going to put into place. They're there to protect the participants, primarily the confidentiality and data privatization. Anonymization with personal information should be removed or coded to protect the identity of the participants and make sure that they stay confidential. Secure data storage should be done on encrypted servers with access restricted to only authorized personnel. Data use agreements should be written and outlined on how the data will be used, ensuring it will not be shared without the patient's consent. Informed consent, again, that they need to make sure that the patient is given the risks and the benefits, and they should understand that participation is merely voluntarily. Documentation should be obtained from each participant in the study, and they should agree with all the study aspects. Minimizing participant risk. We will do this by monitoring for adverse events. They should be done with regular check-ins to monitor any adverse related events on the oral contraceptive use. The participants should also be informed and educated on the risk of strokes and their signs and symptoms. If by chance a patient does have some considerations or are giving any high signs of risk and potential adverse events, they will then again be referred to a healthcare professional. The data integrity and quality assurance is also very important. Audits are very important and should be conducted regularly to ensure the accuracy and the completeness, and proper training must be given to those who will be collecting the data in this cohort study, just to ensure the consistency is throughout the entire time period. Ethical review and oversight committees should be formed and put in place so that they will ensure that the protocol is met and that it stays within the ethical standards. An actual ethical review and oversight should also be done to make sure that the recommendations or modifications are given as necessary. Safety measures are very important. Risk assessments and exclusion criteria should be put into place to exclude patients with thrombotic history. And written reporting and transparency, clear communication must be given to all patients and participants in the study, and as well as a contingency plan for them to withdraw if needed. In this cohort study, we will be using two different types. We'll be using a relative risk ratio, as you can see in the slide that we've given you. We will also be using the odds ratio in our study that will qualify between the exposure and the health outcomes within the actual two groups. Lastly, there will be limitations in this as well. Confounding variables, selection bias, making sure that they don't choose healthier patients over non-healthier patients that would skew the data, temporal relationships, for the duration of the oral contraceptive use. Generalizations may occur when the population selection is not consistent across all lines. And then ethical concerns may arise when women are knowingly exposed to a risk factor if the strong evidence does show that they're at a higher risk than others. The sampling size and power we talked about earlier, we're going to try to get about 2,000 patients if possible, but may need to be increased. The resource intensity may be limited due to the fact that cohort studies require long-term follow-up, which also increases the costs. Compliance and adherence will vary specifically if the participants do not use their oral contraceptives as required. And the reporting and recall bias may also offer some limitations to us because patients don't always accurately take the oral contraceptives.
Further research should be conducted on assessing the impact of easy accessibility of over-the-counter oral contraceptives in heavy smokers or hypertensive women. There's a lot of scarcity of research data on the influence of other contraceptives, such as use of vaginal ring, transdermal ring, and adhesive in the outcome of stroke. Furthermore, younger women stroke survivors face complex and challenging impacts of stroke. It is of paramount importance to carry out more research on how to prevent such incidents in especially younger population and to recognize the early signs of stroke to help prevent debilitating disease in younger population. Next are our references that we have used in the presentation. Thank you for your attention. This concludes our presentation.